really about, it's been several years since the approval of PRT, and um, there's a lot of lessons that have been learned. Some, I don't want to say surprises that have come up, and obviously we've also have some new things that are coming up in the future. Just as an opening, you've UCSF has now done, I don't know how many hundreds of PRTs at this point. Um, but were there any surprises or interesting lesson learned that you've learned along the way that sharing to others?
Oh, that's a good question. So I, I think the what you learn over time, the experience that you learn as you start treating patients, and this is true with every type of therapy, is trying to better understand who should or shouldn't get it. And I think when you first come into it, you sort of get this impression that everyone should get PRRT. And as you start to treat patients and you learn who does well and not as well and what the toxicities are, you start to learn clinically where it should be used. Now, there's not a lot of information to tell you about that all the time, and it's interesting how varied that practice is across sites. But I think that's the part that's sort of an art form and the hardest thing to do is, you have a drug that's labeled in somatostatin that are positive tumors, which doesn't tell you when to use it in terms of sequencing. It doesn't tell you the volume of disease that you should have before you should get it, et cetera. So there's a lot of things that I wouldn't say we have learned. I've learned more about what I don't know than what I know.
So, talking about toxicities, one of the things that has come up on Facebook recently, and I know I want to say there were some myths or some ideas that going into this, I remember early on, people were really worried about kidney protection. And I know the amino acids have greatly improved since this was first released, or since this was first approved. Um, what are the issues with the kidneys now that we have easier to take renal protection? But now that there is renal protection, which for the first few years back in the late 90s, there wasn't renal protection, which is where a lot of this concern came from. But what do we see in kidney issues that come from this?
Not much. Historically, when you refer to Europe, and you know this better than I do, a lot of the kidney toxicity was actually in literature from yttrium 90 PRRT. And yttrium has, for various reasons, likely more associated kidney toxicity. There is not very strong evidence of kidney toxicity associated with PRRT that's lutetium based, particularly when amino acids are administered, given along with the PRRT. So we haven't seen what I would call significant kidney toxicities, but at the same time, kidney toxicity is very hard to associate with PRRT. When you think of like low blood counts, cytopenias, low white counts of red blood cells, that's very easy to say that's PRRT cell. It happens immediately after, it resolves. I know that's what caused it. Kidney toxicity is chronic, long term. It happens over years. It's very hard to tell. If you have a patient who comes in with severe diabetes, maybe not everyone on this call knows that, but diabetes is associated with kidney injury. How do you know that the person's worsening or patient's worsening renal function is due to PRT or the underlying pre-existing condition that's causing their kidney injury? So overall, I think we don't really fully understand the direct causality. It seems to be very, very uncommon. We have treated patients with low GFRs and haven't seen their kidney function get worse, but those are anecdotal. It's not large populations, but 5 or so people with GFRs. And GFR, if you guys don't know the definition of that, it's the how much your kidney clears every minute. So if you think about this is a water bottle that's 12 ounces. I don't know, 12 ounces is probably what, 250 milliliters, let's say. I don't actually know off the top of my head. But a normal GFR would be maybe 100 to 120 mLs per minute. So you're taking about a Coke can a minute goes through your kidneys and gets cleaned. Less than 60, you start to be in this category of having kidney injury. Less than 30, that gets to be more severe. When you're down below 15 or 10, you might be thinking about dialysis. So typically we think of patients with a GFR, or this volume of liquid that's being cleaned per minute, getting less than 30 is where we might not do PRT. But we haven't seen any significantly associated toxicities in that patient population, oddly enough. I don't know if that answered your question, Joss.
No, that really did answer my question, and it really, helped say that we don't completely understand, and there's lots of things that can lead into, having challenges with the kidney, and where to address that. And we're all on a lot of therapies that could also, over time, do some damage to our kidneys as well. And so it's hard to put it specifically on a particular therapy, but it's important to watch for these things just in our general health, which is true for a lot of things that we go through with any of the therapies that we're going. I know one of the other big questions that follows on here, and we'll have we asked out some questions, and some questions are coming in the chat. But follow on PRT. Clearly, in literature, and you've talked about literature as well, people do retreatments past the 4 treatments. I think treatments and cycles get confusing here, but after having 4 separate treatments, which is usually what's on the label for FDA Lutathera, what is the where are we going to understand who might benefit from having more treatment, and how we can decide both dosing and whether it will be safe and effective. And I know that's probably a half-hour talk, but let's see if we can get that down. 20 minutes you can do.
I can talk as long as you want about whatever you want. You know me, but I won't talk for half an hour on this. I will get my tea going now. So retreatment.
As will I.
Yeah, that's probably healthier than my tea. I think of retreatment in sort of 2 pieces. It's sort of the efficacy and toxicity, right? So if a patient goes through PRT the first time around, gets their 4 cycles, and they do well, right? They have a long, what we call a progression-free survival, long time of the disease under control. How long that is, it's not entirely clear what the right answer there is, obviously, but your disease shrinks maybe, or the disease stays stable for years. That would be a person you'd consider retreating. If their lab values do well, the first set of treatments, there's no significant low counts, the bone marrow does okay. We don't have evidence of mesenteric ischemia from some mesenteric mass, things like that that complicate PRT. So if you don't have the toxicities that we'd be worried about, and you benefit from it, that's a patient that clearly we would want to consider retreatment. Now, the question then becomes, well, let's say my counts went down and then they rebound and they're back normal now 3 years later. Then you have to have a discussion. Okay, well, how many cycles do we want to try during retreatment? And we don't usually think about doing all 4 cycles again. Maybe we would do 2 cycles and see how it's tolerated, see how well the patient does, things like that. So that's how I generally think about it. Now, there's actually very little good data. What I mean by that is there's clearly no prospective data. There's retrospective data out of single centers in Europe, which Josh, you know very well as well. And it does show it's effective, but there is a bias in that literature, right? Which is biased by what I just described. If I'm taking a patient who did really well their first time they saw PRT, good guess that they're going to do really well the second time around, right? So you're actually weeding out all the patients who didn't do well the first time from your results in the second round trial, if that makes sense. So you're actually sort of biasing your population to look better than it is, which is actually the point, right? We're using their first response to select them, but that data looks more optimistic than an all-comer retreatment trial, if that makes sense.
Right, but of course, you probably wouldn't do an all-comer retreatment trial, because if they didn't do, if someone, wasn't stable on this before, it would seem challenging to want to try again, so to speak. This brings up a whole bunch of, when we look at retreatment, or when we look at even first treatment, right? Knowing where and when PRT or Lutathera, in this case, it's an approved product, although there are other things in the pipeline, when you would think of putting this in, and just like in any kind of treatment decision, even retreatment has to be done in an environment where there are other options as well, right? So now we're 3 years into this since an approval, and do we have any more clarity on where this sits in when you treat someone, how you look at, or are we still at the grade I call the or? where this is one of a set of options and where we put this or in that. And when it comes to retreatment, how do we look at this again when, at any moment of retreatment, we have other options available to us?
Yeah, I mean so no, I don't think significant information has come through in the last couple of years that changes the way we evaluate. But I think taking sort of examples here might be helpful. So if you had a patient with a small bowel neuroendocrine tumor who had PRRT and did pretty well, there's not a lot of good options in small bowel, right? It's everolimus is the only other real treatment that exists in that patient population. So I'm much more likely to do retreatment actually in a small bowel patient because of the dearth of alternatives in that patient population, as compared to a pancreatic neuroendocrine tumor. And I know, Josh, you're an example of a pancreatic neuroendocrine tumor has gotten lots of retreatment. But CAPE-10 is a very good alternative. It has very good efficacy. We know its toxicities. It's been through, prospective trials. And if someone does reasonably well with PRT, I think it's not unreasonable to try CAPE-10. Not that we wouldn't go back to PRT after the CAPE-10, but that's a very good alternative. So it really depends on what that patient's seen before. If they had gotten CAPE-10 before they got PRT, then I would consider retreatment with PRT more strongly. So it really, again, depends on the specific patient, depends on what they've seen, and depends on what the alternative options are available. And also, obviously, you have liver-directed therapy and all these other things that you need to be thinking about. So it's a little bit complex, but I think thinking about it in that way might give a little more granularity to the thought.
So let's add some more complexity to it, just because we can. And that would be, now we're seeing lots of clinical trials that are that are PRT derivatives, or not, maybe, or Lutathera derivatives, or completely other types of PRT. And we're not doing a presentation this time, but roughly speaking, for those in the audience, right, PRT is a catch-all phrase for a peptide somatostatin analog like dotatate or dotatate that's holding an isotope that's delivered. And so you can change the peptide, you can also change the isotope, and you can change other things in the environment. And we're seeing a lot of clinical trials. You're offering one or two clinical trials, I think, in PRT now that are different than the standard Lutathera. There's trials at the NIH with combinations. We have alpha trials that are certainly gaining a lot of interest in Houston and other places. How do we evaluate when to look at those types of trials, as opposed to just is not a great word, because really lutetium-177 therapy is probably going to be the workhorse for neuroendocrine tumor patients for a long time. But how do we evaluate when we should look at a trial, or how do we evaluate that?
I mean, that's a great question. So obviously it depends on the trial, right? Because each of these trials will have what I would call a different risk profile. And you got to think about clinical trials in terms of potential injury to the patient. So with Lutathera, lutetium dotatate, we have a good understanding of the toxicity. It's been in hundreds of patients. We have prospective trial data. It's FDA approved. It's standardized. And so we know, we have a good confidence of what's going to happen, where we should use it. Although I just said 20 minutes ago that there's a lot unknown, which is still true. Now, the other trials, I think of the trials out there as maybe in two sort of categories. Well, let's put three categories. One is Me Too's. So like lutetium dotatate, right? The COMPETE trial, things like that. In essence, their toxicity profile is going to look very, very similar to identical to lutetium dotatate. So I don't think I would be fine with people enrolling that at any time in their disease course. There's the NETTER-2 trial using lutetium dotatate up front. You have to do that before you do anything else, but it's using a well-described drug we know about, et cetera. So those category trials, I think, aren't particularly, it's not unknown. The next category of trials I would think about is when you're doing combinations, right? So you're taking lutetium dotatate and adding some other therapeutic to it. An example of the risk here would be a trial like ControlNet, right? So this was an Australian trial where they combined CAPE-10 with lutetium dotatate. Sounded like a good idea in higher risk patients, but it ended up being associated with a much higher rate of marrow injury, particularly the leukemia myelospastic syndrome that we worry about long-term in patients. I just want to bring that up as highlights that when you're using combinations you haven't used before, we don't know those toxicities. And so those trials are usually situated in higher risk patients where their disease is more likely to progress, where that risk of the combination therapy might be worth using in that setting. I bring that up. So, for example, a PARP trial, PARP inhibitor is a small molecule that sort of inhibits DNA repair in the cells, and so potentially potentiates radiation damage to tumors. And so there are trials combining PARP inhibitors with lutetium dotatate. That can also be associated with higher risk of marrow injury as well. Those trials are situated in patients who have higher risk disease, higher grade disease, faster growing disease. And I would think of it as a patient of considering using it in the setting at either post lutetium dotatate or in a setting where a patient has more aggressive cancer. We're taking that risk. I think the third set of trials are the trials where we're using different types of radioactivity, in particular actinium or lead, these alpha emitters. And this is a single, these are all single agent trials. Actually, there's only one right now, but there'll be more for better or worse coming down the pike in the next year or so. Those trials are, we sort of know a little bit about the biodistribution, right? We know where dotatate goes, so we can have an understanding of the associated toxicity. But we actually really don't understand the relative risk of toxicity versus efficacy. And this is where we really need prospective trials. And so if I were thinking about a slow growing small bowel neuroendocrine tumor patient, I would not refer them to any of these trials, right? Lutetium dotatate works very well in that patient. But, there's potentially 3 years of progression-free survival. It's not a good patient to put them on a study where there's potentially additive risk. And so I think all of these studies, it's important to be considering the risk and unknown risk of the therapy that's being evaluated, and then your individual rate of growth and aggressiveness of your tumor, and your individual appetite for risk. So I think that's sort of the point I want to get across. I don't know if that touches the points you want, Joe.
No, it exactly does, and it covers a wide range of ways to evaluate not only the current trials that are here, but the trials that are inevitably will be coming down the pike, as you said, and not to plug a trial that you're the PI on, but I know that sooner or later, and I'm hoping sooner, there is a LungNet trial that will be opening at some point. Do you want to give any updates on that as well? Because I know it's on one of the cooperative group sites, so that we can publicly talk about it.
Never know what you can publicly talk about.
I know it's challenging.
This I would put in the category 1 trial of the 3 categories I just gave. It's a randomized study in bronchial neuroendocrine tumors of lutetium dotatate versus everolimus. Everolimus is the only FDA-approved drug in bronchial neuroendocrine tumors, and it's a head-to-head trial. The reason I put in category 1 is using lutetium dotatate. We know the toxicity of it. We just don't know the efficacy in the bronchial setting. And so the goal of this trial is to really have a prospective data evaluating it in a somewhat uncommon subtype of neuroendocrine tumor, bronchial neuroendocrine tumors, so we can evaluate if it's actually a drug we should be using routinely. We do use it already off-label based on sort of small trial data outside of the United States, but this will be the first prospective randomized trial to actually evaluate lutetium dotatate versus everolimus.
And that should open up not only at your centers, but because we have people here from across the country and certainly in Washington State as well. So that should open up across the country, correct? I mean, how many sites are you looking at this point?
Well, so, the cooperative group setting is hundreds to thousands of sites. They won't all open it because probably it'll be limited to the sites that offer lutetium dotatate, but there will be sites nearby anyone on this call who will have this trial open. And so once we get open, we'll really obviously need to increase the awareness of it because if you go to a medical oncologist and you get given everolimus, because that's the FDA approved, then you're no longer a candidate for the trial. So we need to catch patients early before they actually get started on any of these therapies so that we can enroll them and learn. Because you probably are going to receive both of these therapies anyways during the course of your treatment. We should use each individual patient to help get some information to help us decide what's best for future patients as well.
Right, and that brings up another good point that obviously, PRT, while an effective treatment, with 3 years of PFS, at least on the Lutathera on the NETTER-1 trial. As with many or most of the things we do, very rarely leads to a cure, and that at the end of the day, we will be cycling through a lot of different treatments in order to continue extending our lifespan. So I think that's important that even with this, at some point you will probably progress and need to look at other therapies. So understanding what your options are at any given moment in time is always really an important thing to do. Because I think a lot of people, think they're going to have a treatment and this might lead to a cure, and we're certainly not there yet with Lutathera or most any other treatment that I know of or any other treatment I know of for NETs at this point, other than curative surgery with limited local disease.
Yeah, I would even I would say no C word ever in nets. The way I talk about it, and I used the C word in a prostate setting the other day and I get lambasted. But in neuroendocrine tumor, I'm pretty confident that we don't cure patients, pretty much period. The way I look at neuroendocrine tumors, and Josh, you're a very good example, is I think of it as a chronic disease. I want to take neuroendocrine tumor and turn it into diabetes, right? It's a disease that you live with over a long, it's a long period of time that you have it. It's not something that's lethal immediately. And so, it's not that where I'm looking towards creating a cure, but I want to create it into something that patients can live with a good quality of life for as long as
You,
possible.
you want the other C word, chronic,
Chronic,
which is,
there you go.
there you
Yes.
go,
Although
chronic,
that
and
has like
that.
negative connotation too.
Yeah, I know, but that you can live with it for a long time, by changing treatment regimes and such not. So since you brought up prostate cancer, and I think this is the first time that we've had you with this group since December and your PSMA 617 approval for gallium 68. And I know that you've, on several both interviews and others, have talked publicly about how your experience with NETs helped shape, help guide and really accelerate approvals and work in other areas. So if you'd like to go a little bit over PS 617 and how your work in NETs and gallium 68 helped there.
Well, first I'll correct you that it was PSMA 11.
Oh, PSMA 11. I'm
PSMA
sorry. I had
617
617 as a therapy one. Sorry.
But that, yeah. So, if for those of you who are not familiar with this, gallium 68 PSMA 11 is in essence to prostate cancer as gallium 68 dotatate is to neuroendocrine tumor. And so, years ago we were doing gallium 68 dotatalk, and Josh was very instrumental, as well as many of the patients. Some of you on the call participated in that study, getting experience. And I think actually through Josh's lead and the FDA and the SNMI, just this understanding that academia can get a drug approved, which is not that common. And I don't know, some of you are probably familiar with the University of Iowa got gallium 68 dotatalk FDA approved, which is important, although you can't really see the importance yet, but it will start to become important as the manufacturers create a kit that I think is going to be submitted soon. Josh, you probably know better than I on that. But that will make it much more widely available, create competition and wider availability of somatostatin receptor PET imaging agents, particularly when copper goes off pass-through at some point in time, which will create this crunch of availability again in 2.5 more years. But that experience led me to believe we could do this again with gallium-68 PSMA. And it has a huge impact in prostate cancer patient populations, just like the imaging did in patients with neuroendocrine tumor. And we were actually incredibly fortunate to get an approval of the drug in December. The nice thing about prostate cancer is it's big. So the kit manufacturer actually already submitted their ANDA, and it should be reviewed like this week or next week. Like we should hear very, very soon, unless they had issues, which is actually pretty likely given this company. So there actually might be wide availability of the drug that we got approved pretty soon, which would be exciting.
Oh, that's really exciting. I didn't realize it was that was happening that quickly for that. That's fantastic. And again, right, the experience from gallium 68 and specifically those that, and you explained a little bit with the University of Iowa, they work through getting a drug approved for gallium-68 dotatalk at their center the way they made it, and they actually did an academic, or not an academic, they did a, an individual NDA for how they were producing it, and they did something called releasing exclusivity, which meant that anyway, I kind of, since I'm from the software world, I kind of looked at it like open source. Anyone can, as long as they're using the source and can show that they've used the source, can apply to have it approved as well, and allowed that to happen, much like you did with PSMA 11. Sorry about 6, 7. There's all these numbers and acronyms that are going on that make things challenging.
I'm sure half the audience is this is just alphabet soup, but
Uh,
we'll keep
yeah,
talking.
alphabet or number soup, but that's all right. Other things, looking at both the 3 years of work that you've done in seeing patients, the questions I often get, obviously the kidney protection we talked about, and you've done this before, but safety concerns about being around others, post-therapy. I'm curious, someone passed me the UCSF document, which said to eat with plastic utensils for 7 days, and I was trying to figure that one out for PRT. That sounds like a radioiodine thing, but how these things get into place, and what surprises you with the radiation safety challenges that are there as well, or what have you learned about that, and how to best describe that to people?
Well, what surprises me is that my institution hands out a iodine guideline to a PRT patient, but that's a separate issue that we need to make sure that doesn't happen frequently, at least. But yeah, I think what's surprising to me maybe is actually how straightforward radiation safety is with lutetium. It's much easier than with iodine. The dose rate to people around the patients is much lower. The two main risks with lutetium is urine, and then emitted photons out of the patient. The urine's pretty easy. Then you just got to sit down, double flush, wipe your hands, make sure all the urine goes down the toilet, use soap and water. But other than that, that's pretty straightforward. And then the other one is going to be minimizing exposure to people around you. Now the exposure is pretty low. So I did a calculation back when Josh first asked me to give a talk on this. So if I were to stand 3 feet away from someone who's just treated with PRRT for 10 hours, stood 3 feet away for 10 straight hours, the exposure I would receive would be equivalent to a chest x-ray, which seems pretty low to me. And so that, when I calculated that, I was actually really surprised by how low it was. And so if you think about that from, if you are a caregiver, someone who's being treated with PRRT, you're probably not within 3 feet for 10 straight hours at all during a day. And so the exposure is going to be less than that. And that's using the dose rate right after someone got treated, right? And so then they excrete out activity in their urine, it decays. So over time, it goes down. So that's why after 3 days, we in essence have no recommendations for patients treated with PRT because the exposure rate gets so low. The example I always give to patients, which it sort of highlights all the points I want to make, which are if you have young kids at home, just don't stick them on your lap, read a book for a long period of time, right? Young age, close proximity, long period of time. Those are the things you want to do the opposite of. So if you're more than 6 feet away from someone treated, in essence, your dose is 0.
Actually, one of the things that I was surprised about when I delved into this a little bit was how much of that initial dose that comes in, the 200 millicuries, is actually flushed down the toilet within the first 4 hours. I mean, as high as 50% of the administered dose, and I think people don't realize that much is already gone, and the things are decaying in rapid fashion afterwards, although not ridiculously rapid fashion. It's still 6.7 days for a half-life, and you're still detectable by our friends at Border Security for about 67 days. And so, And would you like to explain this a little bit as well? Because I think this was what I've seen people buy Geiger counters to measure their dose at home and to do really some crazy things. And one of the justifications is like I can still obviously be picking up some of the gamma with that, but it still registers on a Geiger counter, or the Customs Border Patrol agent can pick me up for 2 months later. How can this be safe if I can be detected like this and I can see it on a Geiger counter? And yes, we do have people who are buying Geiger counters online to measure their dose, or at least see the needles go up at home. So it's yeah, we do crazy things out in patient land sometimes. So do you want to explain why we would see it on a Geiger counter, or why when a radiation safety officer at the airport might be able to detect it, why that still doesn't really impact someone else's health?
Yeah, well, so what they're detecting is, as you said, they're detecting the gamma photon, right? So the lutetium decays by giving off both a beta particle and electron. That's what kills tumors. It also gives off some gamma photons, which can be imaged. So that's how we image patients the day after. But it can also be detected by a Geiger Muller gamma counter or at the airport. Now, what's lots of things give off radiation. You go into your basement, if you'll detect radiation, right? Radon is like one of the highest sources of radiation to people in the United States. You go up into an airplane, you're going to have a higher dose of radiation just by doing that. So it's not about yes, no, is there radiation? It's about the amount, the dose rate, and the exposure that matters. And so when you are getting more exposure, standing someone who got treated with lutetium dotatate, just the exposure is about equivalent to flying in New York. A chest X-ray is about equivalent flying to New York. So if you flew to New York, you should be just as afraid of the dose of radiation from that plane flight as standing next to someone for 10 hours, 3 feet away from the day they were treated with lutetium dotatate. Now, I'll tell you, the risk is not equivalent to people's perception of the risk, right? No one doesn't get on an airplane because they don't want that exposure to radiation. It probably doesn't occur to anyone to even think about that. But many people get worked up about the radioactivity exposure from treatment with lutetium dotatate. That's very different from the patient exposure. Patient exposure is much higher, obviously. I'm talking about people nearby.
Right, because you're also, I mean, obviously you have beta emitters that are sitting right on the tumor, which are far more powerful and do actually the damage that you want it to do. Since you brought up imaging, and actually I even saw a post of someone who was sleeping in a separate room for 3 days post a gallium-68, which since it only has a 10-hour, a 68-minute half-life, there's not a chance that you need to sleep apart from your partner overnight with a gallium-68 scan. But one of the questions that's come up in the chat box is on copper-64. I know you're doing both copper-64 and gallium-68. How's your experience been with copper-64? Is it imaging pretty much the same? Are you using them interchangeably? Why are you doing one versus the other? Obviously, one can come pretty quickly to you if you need and also gets reimbursed by Medicare. But other than those two things, how are you handling those?
Yeah, so the last two things you mentioned, sadly, are probably the primary motives for using it. The gallium, you can make one dose per synthesis on a gallium generator. And there's only 2 or so gallium generators that can deliver to our facility. And they make doses at
I
specific
have one
times.
here.
Yeah, obviously, doesn't everyone carry their gallium generator around with them? So the problem with gallium is that your scanner has to be available at the time the dose is being made, and another hospital can't have already taken that dose. So it was very difficult for us to schedule gallium dotatates, just solely due to scheduling, which is sort of a sad reason to switch, but it's really important, right? I don't know, some of you might have tried to get imaged here a couple of years ago. It would take 6 weeks to get on the schedule sometimes because finding an open slot with an open dose being able to be delivered was actually not that easy. The second thing is Medicare doesn't pay for gallium-68 dotatate, and that's $4,000 down the drain for the hospital system. And
So I need to be
That's
clear
up.
there. They pay for the PET CT. They don't pay for the actual imaging agent that you have to buy. So it's not that they're denying, and they don't deny the scan. You can still have the scan, but they're not paying for the drug. There's some confusion when we say those
Fair.
things. So
And I should
um,
add that if they don't, with Medicare, you as a patient don't see any of this discussion. If they don't pay the drug, it's us at the hospital who doesn't get, it never comes back to the patient. But the cost of the drug is about 3 times the cost of the scan. And so if you, if you're not getting covered for the cost of the drug, you lose lots of money and that adds up to nearly 7 figures a year for our hospital. uh, Money makes decisions. So copper 64 works great. It's a little noisier. It has some imaging characteristics that are slightly different from gallium that make it a little harder to image. But when you adjust your protocols a bit, the image quality is great. And particularly for things that have uptake, it works actually really well. There's a lot of noise in the background. It's a noisier background, but the actual uptake in the tumor lesions is very, very nice. It has a longer half-life, so 12 hours instead of 68 minutes. So you can do some more delayed imaging and things like that. But it's a perfectly fine imaging agent. We like it. It has maybe, I can't remember, 25% higher dose than the gallium-68 dotatate. So it's a slightly higher dose, not dramatically higher, but slightly higher to the patient. But for us, given that we viewed them as equivalent imaging studies and the benefits of the feasibility of actually doing it, the scheduling and the reimbursement was a pretty easy choice for us.
and can you go back and forth if you've been imaged with gallium 68 and you go to a copper 64, but then either because of availability or whatever reason you flip back, is there a challenge there?
That's a great question. I would say there's a slight challenge there. Uh, so you can't compare SUVs, the uptake, the measured uptake between the two. They'll be different. But I'd also say we generally don't use SUVs between gallium to gallium either to evaluate for response or progression. We look for new lesions. And so the issue with copper to gallium is it's noisier, but it actually sees smaller lesions a little better. For whatever reason, I can't exactly explain that. So you do seem to see some of these lesions sometimes better and sometimes worse on the copper, depending on the size of the patient. There's just differences in the technique. So in subtle progression between the two, it can actually be somewhat hard to compare apples to apples when you're going down to copper. And I would say it's equivalent to using 2 different PET scanners. So each scanner can have different sensitivities and reconstruction parameters, and they can have different sensitivities, even if you're using the same radio tracer. So it's sort of in that same level. It's not a dramatic difference, but definitely if you're looking at a subtle change in the distribution of disease, it can be hard to appreciate whether that's true or not when you're comparing gallium to copper, or again, 2 different scanners.
And is one better on an MRI versus a PET versus a
Same
CT? They're
detectors.
both and they're as noisy on each one of them as right.
The better your scanner, the less noisy they'll be on the copper side. So I don't exactly know what that means. But for example, we just installed our new, big digital PET CT that's going live today. We did our first gallium patient today with PSMA, and so with those scanners, it becomes less of an issue, if that makes sense. We don't have any of the scanners anymore, but an older school scanners, so non-time of flight, non-digital scanners, the copper can be a problem. Now that can be addressed by changing your protocol. So that actually a lot of work's been done in the last year, but you have to change the amount of acquisition time and reconstruction parameters, and you can help overcome it with that.
And and certainly now with your center as well as many others in California, patients are getting their report right after they're read, which provides a challenge on a lot of the language that's going on, and that's probably a webinar for another time. But one of the things that we see on this is SUV, and you kind of mentioned what SUV. That you don't really cross-compare SUVs between studies anyway. You're looking more for size, but do you want to go over just a little bit about how people should interpret, or how they should interpret what SUV is, and how they should not worry about interpreting between different numbers?
So SUV stands for a standardized uptake value. The way I think about it is if we injected the radioactivity into a patient and it perfectly distributed throughout the body of the patient, the SUV would be 1 in any specific voxel. As the activity concentrates in a voxel, the number goes up. So if the SUV is 2, that means that voxel or the pixel has twice the amount of activity if the activity were evenly distributed throughout the patient, if that makes sense. So it will wash out of background.
Just using the term a little bit, voxel or being like a grid part, that
Yeah, like
little.
a unit of the image.
Right.
Um, yeah,
Okay,
so like
go for it.
I think of like a pixel on a TV. If you're looking at your image, one dot, the number that's ascribed to that dot is going to be your SUV. Each dot has different SUVs, and the SUV is determined by how much of the radioactivity concentrates in the voxel. So lots of things can impact the uptake. So tumor uptake in neuroendocrine tumors is pretty good, right? The SUVs are 10s, 20s, 30s, 100s. We've had patients with an SUV of 300 and something, which means the radioactivity really concentrates into that tumor, okay? Now, people have done some more correlating response to PRRT to SUV. If it's not obvious, it probably should be. The higher your SUV, the better you're going to do with PRRT in an intra-patient comparison, because the higher your SUV, the more the radioactivity is going to go there, right? It's taking up more of the dotatate, or the somatostatin receptor analog. That's biased, though, because patients with higher SUVs also just do better in general. They probably have more well-differentiated tumors. They're more likely to be G1 tumors, et cetera. So there's a lot of different biases that go in. That does not mean that if you have an SUV of 10, 15, 20, 30, you shouldn't do PRT. It just means that patients with higher and higher PRTs are more likely, on average, to have a better response to PRRT. Now, SUVs can be impacted between patients by a couple of things, many things. But if you take lanreotide or sandostatin, the timing of that relative to your dotatate will probably change your SUV a little bit, maybe 5 or 10%, something like that. So that can vary it. There's probably things within the tumor we don't understand, other drugs or things that interact with the expression of the somatostatin receptor. The other thing that really does impact the SUV is the tumor volume. So there are patients, if you get larger tumor volumes, it sucks up the radioactivity. In essence, it distributes across that entire volume. So the SUVs overall go down. So you can have patients who have an SUV of 20 but have very high tumor volume who are great candidates for PRT, right? None of it is going to the kidneys because the tumor sucks it off. So all these different things impact and change the SUV. And so overall, I wouldn't put too much thought into the SUV, it changing or anything like that. I use dotates to tell me where the disease is. Is there new disease or not? Is this disease growing or not? It's like a map to tell us where we need to look. Because oftentimes I wouldn't even know that lymph node was actually a tumor, so I wouldn't know to look to see if it grew or not, because I wasn't knowing that there was cancer in the lymph node. So I would generally not pay attention to the SUV, although it is important to look at in a holistic view. When I think about patients with PRT, I actually don't spend too much time on the SUV itself, but rather looking at the images, looking at the relative uptake of the tumor versus the liver and the kidneys, the biodistribution, because that will tell you a lot about what's going to happen when you treat the patient with PRT.
And to that, bringing up, looking at someone being more avid or as a way to at least think about how they might do with PRT. Have we gotten anywhere with biochemical testing, or has that improved, or what will it take in order to really think through how some biochemical testing? Because I know there's a few different ideas out there now, but where are we in that area? And I realize this is unsettled science, so to speak.
Not sure I want to answer that question, Josh.
Yeah,
It's
that's
a
fine.
loaded question.
Well, are there studies to look to try to validate either combinations of biochemical markers or specific ones that are new and different that might end up in a NCI trial or something like that?
So let's break it up into
I'll
two
give you an
categories.
out. I'll let you get an out on that one.
Let's break it up into two categories. There's biochemical tests that are hormonal markers, chromogram, 5-HIA, gastrin, VIP in your case, et cetera. So there's blood markers that the tumor secretes, goes into the blood pool, and we can measure those. In general, those are not particularly helpful to follow time to time point disease progression. right? Did your chromogranin go from 1200 to 2200? Is that progression? I have no idea. And honestly, I think most people in the United States and most of our guidelines have agreed to no longer measure chromogranin because there's little value. Now, if on the other hand, you're like, Josh, you have a tumor that we know secretes a specific marker like VIP, right? That can be very valuable to track over time. It also correlates with symptoms. So, for example, 5-HIA is not maybe as helpful to tell if someone's progressing or not. But if you have a 5-HIA of 400, I do actually really care about that because you're going to be very likely to potentially develop carcinoid heart disease or other complications. So these markers have roles, but generally we don't use them in a vacuum to equate to progression or not. And imaging really, I think, still is the major way of doing that, and it's actually pretty good at doing that. And I think we can stick with that. Now, there's different categories. There's a bunch of things, and the ones that people are talking about most are things like the NET test, which are these sort of blood-based markers, which are black box. They don't tell you what they're measuring, and I'm not fully convinced how we should use them clinically or what they mean clinically. And there is, as Josh says, a huge need to validate this and see how we should be incorporating them into management of patients. It's very unclear to me what the individual value of these are, and studies need to be done by people who don't have a relationship with the test. I don't know how to say that more strongly, but I think it's really important that the person publishing results of a test does not have a relationship with the test
Well,
itself.
and also, you know, do this in a way much like an NCI trial does, where it's pretty much blinded
Blinded.
to right to and there's a couple things to do that, and there's more, not to single out. There are some other combinations of tests that have been proposed, and certainly, and I think it will be interesting, to validate in a prospective trial that's run by a third party how these things pan out, and if they pan out successfully. Because I think, as you said, you wouldn't not treat a patient who had an appropriate SUV and that was the appropriate option so far based on what you've seen. And that's probably the safer way or not safer way, but the other way of putting it. But one other thing that we haven't touched about a little bit, and you and I have certainly had I would say, a ton of conversations at times on dosimetry, and understanding what dose someone has gotten, and whether, how we would use dosimetry in the future, or how we would answer that question. I don't want you to give away anything that you don't, but we've heard about dosimetry for a long time. There are centers in around the world that use dosimetry to try to guide therapy, but I don't think we've seen any good. Every time this comes up, I don't think we've seen any great clinical validation of where dosimetry really has hugely mattered. So I don't know if you want to touch on dosimetry and how we might use it.
Okay, so dosimetry. What does dosimetry mean? Dosimetry means we inject the lutetium into you, and then we can actually image it directly. Right? We can image you the next day, the patient, in a SPECT scanner, and see how much of that dose went to the tumor. Right? So we can actually literally directly measure tumor dose or organ dose, the kidneys, after you've treated someone. And you can do that for every cycle, et cetera. Now, I think of dosimetry, let's take it into sort of three categories. One, qualitative. I've been surprised by how valuable qualitative dosimetry is. What I mean by that is you can just look at it and you can see how patients' disease is changing over time. You can also see if there's abnormal biodistributions, if the activity collected in the kidney collecting system is sitting there for a day. So from a toxicity standpoint, it's marginally helpful for that reason. We've had a couple of patients where we have stented them to drain their collecting systems and who had obstructions that we weren't aware of. Now, from qualitatively looking at it, I find it helpful in some patients to see, you can see disease shrink over time. Like as you're treating them, you don't need a dotatate PET every time. You can just do an imaging study the next day. And this is why we do it at UCSF, is we can actually see the trajectory of the disease. We can see if it's stable over time, if it's doing better. And this is particularly helpful in patients where maybe there are some low counts developing, platelets are going down, or white blood cells. And I really want to know, like, do I need to get an extra dose in there or not, right? Is the patient beginning to respond? How are they doing? Do we want to lengthen it out? And it also, particularly in bone dominant patients where you can't really see it except on a dotatate PET, it gives me a nice response biomarker during therapy. So qualitatively, I actually surprisingly find it more useful than I had anticipated. Now, qualitative dosimetry, which is what Josh is actually asking about, is where you can actually measure the dose to the kidneys in gray. Right? Gray is a unit of exposure or energy deposition into tissue. And so we can actually say, hey, your kidney got X amount of dose, your tumor got X amount of dose. Now, most of the dose trials in the world right now, the institutions that are using dosimetry are using kidney modulated dosimetry. So they'll say, hey, we're going to give you 30 gray to your kidneys, and we're going to give you a dose until you get to 30 gray. And my personal opinion is, doesn't make any sense, right? We just talked about how your kidney is not your, target organ. It's your bone marrow that's getting injured the most. So I don't actually understand why I would blindly escalate someone's therapeutic dose until, like, just keep going until we kill the kidney while we injure the rest. I just don't get it. So I don't understand those trials. So I think we need to, as a community, really think about how dose is used in therapeutic studies and in individual patients. And right now, I don't actually see any studies out there designed in a way to answer that question. So what Josh is getting at is we had this planning meeting to talk about trials in the future. And one of the things we've discussed is dosimetry. And I really think we need to take into account the dose to the tumor and the response to the tumor, while we also take into account the dose to the target organs, right? I want to get X amount of gray to your tumor. If it's gotten so much dose, then I don't need to keep escalating until we get to 30 gray, something like that. But that has actually not yet been done in any respect, which is sort of disappointing. But hopefully, I would say in the next year or so through the NCI, maybe we can help develop trials that will address that question, because it's a huge issue. And it's the whole point of lutetium dotatate is you can see your therapy, right? We should be personalizing that. But the question is, how do you personalize it? How do you use dosimetry to best personalize the therapy to the patient? And in all honesty, we're not there yet, sadly enough.
So, and yeah, no, I think that's a better, I don't want to say a better answer than I was anticipating, but it was a great answer and a great explanation, and something that I will replay so I can do that better as well. Lutetium has this interesting characteristic of having both the gamma, the light bulb that you can see, and the stuff that can kill tumors, the beta. When we start talking about different isotopes like alpha doesn't. How do we go image alpha when we do that?
You don't. Alpha, this is a much longer, I said you could have answered that question in 30
Right.
minutes. Alpha is complicated. The micro dosimetry really matters. I mean, alpha particle travels like 40, 50 micrometers. The spatial resolution of our SPECT CT is on the order of a centimeter, right? So even if you could image an alpha particle, it doesn't actually tell me or help predict the dose to the tumor in terms of its efficacy. A beta particle travels a millimeter, so it's far enough that it sort of averages out, and the dose you're measuring is a reasonable surrogate of what's going on in the tumor. With an alpha particle, like here's an example. I have a student doing a lot of modeling of alpha particles. But if you have a cell, and it has a nucleus in the cell, and the alpha particle originates in the cytoplasm of the cell, the nucleus in essence gets very little dose because the alpha particle deposits the maximum amount of energy about 50 micrometers away. It has what's called a Bragg peak. So the energy gets deposited like this. So the peak deposition is actually not even in the cell of the origin. So depending on the distribution of the cells and the density of the cells, alphas may or may not be very beneficial, if that makes sense. So it's actually very complex, and it's very hard. And actually imaging, like with lutetium, might not, obviously the higher the uptake, the better on the imaging, but it's not going to directly relate one-to-one to response. And with lutetium, it certainly doesn't relate one-to-one response. It's going to be even less related with alpha particles. And I think we are obviously at the very beginnings of understanding alpha-based therapy for the treatment of cancer. And there's a lot of work to be done, to say the least.
And we're still learning so much about, lutetium here. Here we're having a discussion about how dosimetry might work and how we make this personalized. And certainly we've been working, or those in the nuclear medicine industry have been working with lutetium for 20 plus years now. So we're still learning new things, and how to better tailor therapy. with something we've had, certainly approved here for 3 or 4 years. But still, we're still just scratching the surface and still learning more. With that, I'm gonna. I know you've given us a long time of your lunchtime, and I want to thank you for doing that. Is there anything else you want to add before I actually stop the recording?
No, no, thank you very much for the opportunity. It's always fun to talk to this group, and I'm always happy to come anytime.
So I'm gonna give me a second to turn off the recording and allow everyone to unmute themselves and say hello, and you can see everyone. I know you can still see everyone even though I've spotlighted you, but let me turn off everything so you can do this more officially. Let's see. There we go. One and